Good morning, doctor and my dear friends. Today, Group 5 members are going to present about ankylosing spondylitis.
And these are our group members.
Our case scenario is about Mr. Ramesh, 28, is an outdoor enthusiast who enjoys hiking. Lately, he experiences prolonged morning stiffness and lower back pain, which improves with activity. He finds it harder to stay active and is concerned about his future mobility, but remains positive and wants to manage the condition naturally. What is ankylosing spondylitis? It is a type of arthritis that mainly affects the spine and sacroiliac joints, where the spine meets the pelvis. It causes inflammation of the joints, leading to pain, stiffness, and reduced flexibility. Over time, this inflammation can cause new bone formation, which may lead to fusion of the spine. And it belongs to a group of conditions called spondyloarthropathies, and it commonly begins before the age of 40. So, what are the common causes? Genetic predisposition, autoimmune reaction, environmental triggers, family history, inflammatory cascade. Now I'll be talking about the pathophysiology. The first one is enthesitis. It is an inflammation where tendons or ligaments attach to the bone. For example, heel pain and Achilles tendon. Second is the chronic inflammatory response. It is an immune system that stays active and ongoing inflammation. Example, chronic low back pain and morning stiffness more than 30 minutes. Third is fibrosis and tissue repair. It is an inflammation heals with fibrotic scar-like tissue. For example, reduced spinal flexibility, especially in lower back. Last is spinal ankylosis. It is a fusion of vertebra from long-term inflammation. Example, stooped posture, unable to stand fully straight, like bamboo spine on X-ray.
Good morning, sir. My name is Anjali, a mental physiotherapy student from UK and KL. So, sir, can I know what is your name and age?
Mr. Ramesh, I'm 28 this year.
Okay, good. So, can I know what is your complaint today?
I'm feeling some pain in the lower back, especially when I wake up in the morning. The pain is a bit worse and it's like lasts quite a while, a few hours, and also some stiffness, especially in the morning.
Okay. How long does that stiffness usually last?
Maybe 2 to 3 hours, a few hours.
Okay, good. So, can you tell me more about your pain, your experience like a dull or itching?
It's more like a bit of aching, a dull and aching pain.
Okay. Is it the pain come suddenly or gradually?
It's gradually, it's like slowly it will come.
Okay, good. Is it the pain reduce your motion?
Yes, it affects my motion a little bit.
Okay. So, is it any motion can make the pain worsen or better?
Worse if I try to flex too much, then the pain will become worse.
Okay.
Better if I'm bending down, it's not so bad.
Okay. Does the pain spread anywhere else?
No, mainly just on my lower back.
Okay. Is there any numbness or tingling?
Numbness, no.
Okay. Do you have any symptoms like weight loss or unusual fatigue?
No.
Okay, good. So do you have any bowel dysfunction or numbness in pelvic region?
Also no.
Okay, good. Do you have any history of trauma, surgeries, or medical condition?
No.
Okay, good. So can I know what is your current occupation?
I'm an office worker, accountant.
Okay, do you spend long period of sitting?
Yeah, most of the time I'm at my desk, so I will sit for quite a long time each day.
Good. So do you have any hobby?
I like hiking, outdoor activities there.
Okay, is this a condition will affect your hobby or daily life activity?
Yeah, so because of the pain, I actually reduced my activity, didn't really go for hiking since the pain started.
Okay. Do you have any family members with similar issues?
No, not that I know.
Can I know who do you live with now?
Staying with my wife.
Oh, okay. Why do you take any medicine now?
I took some anti-inflammatory medicine.
Okay, good. So have you taken any X-ray and MRI before?
Yes, I was.
Okay, so let's look at it. And lastly, what is your goals today?
Mainly, I want to reduce my pain so that I can move better, and also I want to maintain the mobility. I'm afraid that I will lose my mobility, which will affect my future activities.
Okay, thank you, sir.
Here is the subjective findings based on the conversation. Mr. Ramesh is a 28 years old accountant who presented with complaints of prolonged morning stiffness, lower back pain, and reduced range of motion. He reports that the symptoms have been gradually worsening over time and are now starting to interfere with his active lifestyle, which includes the hobbies such as hiking and outdoor activities. We also confirm that Mr. Ramesh not have any traumatic injury and surgery before. Mr. Ramesh described the pain in the lower back as dull and aching with a gradual and progressive onset. He notes that the morning stiffness lasts more than 30 minutes and improves with activity throughout the day. He reports with no bladder dysfunction, saddle anesthesia which rule out red flags. Pain tends to worsen with prolonged sitting. Some action like lying down or moving will help to relieve pain, and there is no radiation of pain. Mr. Ramesh is currently taking anti-inflammatory medication for symptom relief. Socially, Mr. Ramesh lives with his wife and expresses that his condition has begun to negatively impact his quality of life. Goals of Mr. Ramesh include reduction of pain and stiffness, regaining confidence in mobility and daily function, and preventing long-term deformity and disability. Based on the combination of young age onset, prolonged morning stiffness, gradual onset with chronic progression, and pain that improve with movement, we suspect that Mr. Ramesh have inflammatory back pain. For objective assessment, Mr. Ramesh will be evaluated through observation, palpation, range of motion testing, special tests, X-ray analysis, and neurological screening. From side view, we notice Mr. Ramesh have forward head posture, increased thoracic kyphosis, and flattened lumbar lordosis. From the posterior view, muscle symmetry was noted with no observable spinal curvature or deformity.
Sir, now we'll do some assessment, so I will calculate your back region. So sir, can you please take off your shirt? Okay, sir, I will have physical contact with you during this whole process, so is it okay?
Yes.
Okay, so sir, now I need you to lying down with your face facing downwards. I will lower down your pants, okay?
Yes.
Have some palpation. If you feel any pain, can let me know.
Here.
Okay, can hear. Here got pain?
Yes.
Okay.
Yeah, here.
Here got pain?
Little bit.
Okay, little bit. Okay. Here?
Also a little.
Okay.
Based on palpation, Sir complained that he had pain at his lower back and sacroiliac joint region.
Now sir, we would like to assess your range of motion. So now sir, can you please lift up your leg? Okay, in position. Okay. Okay, good. Sir, can you use movement? Okay, good. Another leg. Okay, good. So this leg, do this. Okay, good. This. So I will assess your cervical range of motion. So can you look down? Okay, then press up pressure. Can you lift your pen? Okay, good. So can you look up to the ceiling? Press up pressure. Lift your pen? No. Okay, good. So can you rotate to the side? Okay. Can you please apply a pressure by yourself? Yes. Okay, good. And then look at here. Can you apply some pressure? Okay, also no pen, right? Okay, good. Do this. Okay, so I apply some pressure. Lift your pen?
No.
Okay. So also the other side. Can you look for me? Okay. Can I apply pressure? Lift your pen?
No.
Okay, good. So now I want you to use your body and then can you rotate? Rotate yourself. Okay. Do you feel any pain? Okay, good. Okay, so sir, can you please stand up now? I need you to move your hand to the floor. Okay, so is it pain?
A little bit.
Okay, apply some pressure. Lift your hand. Okay. So now can you put both of your hand at the side and then you do some extension, extend to back. So apply some pressure. Lift your hand. Okay. So now next you do side action. So can you do this? Okay. Lift your hand.
Little bit.
Apply some pressure. Okay. You have pen?
Yes.
Okay. So another side also. Lift your hand.
A bit. Yes.
Next, for the special test, we'll introduce the Buff Ankylosing Spondylitis Metrology Index, BUSMI, which includes Cobber test, lumbar side flexion, tragus to wall test, intermalleolar distance, and cervical rotation. And since Sir complained that he has pain at his SIJ joint, so we'll do Faber test for confirmation.
Okay, so now we are going to do Cobber test, which is to measure your range of your lumbar flexion. So I want you to stay upright and make your feet hip width apart. Later, I want you to bend down while keeping your knees straight as far as you can, and I will measure the distance. And I have already marked the central point between two PSIS and measured 10 cm above the central point. And I will ask patient to bend down. Okay. Here's the result. We'll minus by the 10 cm just now. So the difference is around 3 cm. Alright, sir, we are going to perform the lumbar side flexion test. So I want your heel and back keep against the wall. With your fingers extend, I will measure from the middle finger to the floor. Alright, now I want you to try to reach to the side as far as you can. We'll calculate the difference. Okay, now we are going to do a tragus to wall test. I want your back and heel to stay against the wall and feet 30 cm apart. Okay, I want your head to try to touch the wall as far as you can. Alright. And lastly, we are going to measure intermalleolar distance. So, sir, can you please open wide your leg with your toes pointing upwards? And I'm going to measure the intermalleolar distance. It's around 82 centimeters. Thank you, sir. So for now, we are going to do a Faber test to assess your sacroiliac joint impairment. Okay, I will put your leg like this. Give you some pressure. Do you feel pain?
Yes.
Over here?
Yes.
Now another side. Do you feel pain?
Yes.
Over here?
Yes.
Alright. Yes, sir. This is the result of special tests carried out on Mr. Ramesh. The first component in BUSMI is cervical rotation, and Mr. Ramesh got a normal range of cervical rotation. The second is Cobber test, which is the lumbar flexion test. Mr. Ramesh got only 3 cm, which is less than the normal 5 cm. It indicates a moderate level of impairment. The next is lumbar side flexion test. Mr. Ramesh got 12 cm, which is less than the normal 17 cm. It indicates mild level of impairment. The next one is tragus to wall test. Mr. Ramesh got 20 cm, which is more than the 10 cm. It indicates also mild level of impairment. The last component in BUSMI is intermalleolar distance. Mr. Ramesh got 82 cm, which is less than the 120 cm. It indicates moderate level of impairment. And the last special test we carry out on Mr. Ramesh is Faber test. Mr. Ramesh complained of pain during the test on both sides of the sacroiliac joint. It indicates the sacroiliac joint dysfunction. From the assessment just now, we have known that there's pain when palpate at the lower back of Mr. Ramesh. There is spinal stiffness, positive sacroiliac joint test, and also postural problem. So there is a clinical suspicion of axial spondyloarthritis, which is typical for ankylosing spondylitis. X-rays show signs of inflammation or fusing of the vertebra, which is known as bamboo spine. Ankylosing spondylitis often doesn't show up on an X-ray in the early stages of the disease. But if the X-ray comes back normal and doctors still suspects ankylosing spondylitis, they may recommend an MRI. It shows negative result in all the neurological screening, which include dermatome, myotome, reflex, sensation, and also straight leg raise. Here are some differential diagnoses to be made. The first is degenerative disc disease, which involves mechanical pain. This pain is absent in Mr. Ramesh's condition. And the age onset for degenerative disc disease is normally more than 40 years old, while Mr. Ramesh is only 28 years old. For herniated disc, it involves radicular pain, and radicular pain is absent in Mr. Ramesh's condition also. The next is osteoarthritis, which lack of systemic inflammation, while Mr. Ramesh has inflammatory pain and has an insidious onset of pain. Spinal stenosis, although Mr. Ramesh's condition is improved with flexion, while it doesn't involve neurogenic claudication as in the spinal stenosis. For spondylolisthesis or spondylolysis, it involves mechanical extension pain, which is a non-inflammatory pain, while ankylosing spondylitis is an inflammatory condition. Rheumatoid arthritis rarely affects sacroiliac joint or spine, and it mainly affects small peripheral joints, so it can be ruled out also. To confirm our diagnosis, we review all the subjective and objective assessment results. Mr. Ramesh is 28 years old, which meets the age of onset, common in ankylosing spondylitis, less than 40 years old. He experienced postural changes, in which he has forward neck posture, increased thoracic kyphosis, which is an early sign of ankylosing spondylitis, and also a flattened lumbar lordosis, flat back. He experienced morning stiffness more than 30 minutes. This is common in ankylosing spondylitis. His pain pattern is improved with activity, and he experienced low back pain during palpation, spinal stiffness during assessment. The sacroiliac joint involvement in Mr. Ramesh is bilaterally and also symmetric. This is common in ankylosing spondylitis. For others condition, there will be asymmetric or absent of sacroiliac joint involvement. In addition, there is lack of red flags and he has normal neural exam results. Lastly, imaging MRI showing sacroiliitis or bamboo spine in the leg of ankylosing spondylitis. So from all of this, Mr. Ramesh is confirmed to be diagnosed with ankylosing spondylitis.
For the physiotherapy intervention, we will start with using a cold pack. This is to reduce pain and inflammation so the patient can proceed with exercises. We will also use joint mobilization to improve the mobility and also reduce pain. Next is exercise therapy. So we choose a series of exercises that improves mobility, stretching and strengthening, and also aerobic exercise to help improve quality of life and functional capacity. Our intervention also consists of breathing exercise, which is to help improve thoracic expansion and prevent future complications, as well as postural correction because they may be present with a kyphotic posture. Lastly is patient education, where we want to educate the patient on the prognosis and the causes for the condition, as well as what they can do about their pain.
Correct the posture. So first, can we sit upright and open the chest? Open it. Okay, now we're going to correct the two sides. Okay, can you please move your chin to the backward? Okay, and then maintain for 15 seconds. So now is the progression for the chin tuck. I'll put the ball behind your neck. Can you please move your chin to the backward? And maintain for 15 seconds. So now we're going to correct the kyphosis. Can you please lie on this hand? This forward to get the upper back. And this will reduce the body. So now we'll apply for back and this will apply for knee. Okay, do you feel any pain?
No.
Okay. So now we'll start from joint mobilization. I'll start from grab one first, okay? And can you please tell me, grab one, okay?
Okay.
Okay, going on to proceed to grab two.
Okay.
How about this grab three?
Okay.
This is better, right?
Yes.
Then we'll proceed grab three for 30 oscillation.
Yes.
Turn up and please slowly do a thoracic mobility. Open up and breathe in. And lower the arm to breathe out. Then please go yourself. Okay, so now I give you some lower back exercise. Can you please lean on this backwards? And then put your arm under your shoulder. Okay, so that I need you to lower down your lower back and head up. Okay, and then lift up your lower back and head down. Okay, repeat this movement. Okay, good job. So now can you please sit on this three row? And up at the side. And I need you to lower the body to the side and touch the floor. Okay, so for the other side. Yeah, good job.
Morning, sir. Tonight, I've prepared some posterior chain exercise for you. The first one is called Y-shaped extension. Now, I'm going to demonstrate how to do this exercise. So, you both stand, grab both this to end of the cerebral band. You're standing back a little bit, and you bring some tension with the cerebral band. Now, you raise up your hand over your head and try to pull it backward. Now, let's try. Okay, try to concentrate the muscle again. Okay, very good. Control. Okay, sir, the last exercise for you is called breathing. So, what I want you to do is, sir, would you like to bend your knee? Okay, very good. And try to lift up your butt up from the bed. Okay, very good. Okay, go down and raise up. Goes down. For progression, we can place a gym ball under the patient's tail. Sir, like we did before, lift up your butt up from the bed. Okay, very nice. Goes down, goes up. The next exercise is called back extension. It's mainly targeted on your upper back, and what we need is only a gym ball like this. So what I want you to do is, we find a wall so you can stabilize yourself. We kneeling down and put our feet flat on the wall so later you can stabilize yourself. So you're crawling on the gym ball and find yourself stabilized, and you may place both of your hands below your neck and try to raise up your trunk. Okay, let's have a try. Okay, very nice. Slow and steady. Next, I'll teach you how to stretch your belly muscles. So we need to lay down like this. And we'll place both of the hand side of the trunk and lift your body up like this and hold it for a few seconds. Okay, relax. Let's try. Okay, very good. Hold it 1, 2, 3. Okay, relax. Let's do it again. Very good. Hold there. 1, 2, 3. Very good. Now I will teach you how to stretch the back. The first thing you do like this and sitting down. Open up your leg. Then place the gym ball between your knees. Both hands place on the ball and try to lean the ball forward and trunk leaning forward. You can hold and go back. Let's try. Okay, very nice. You may hold here. 1, 2, 3. Very nice. Rolling back. Okay, clean. 1, 2, 3. Very nice. Rolling back. Okay.
Based on the exercises shown, here's a simple exercise program for the patient to do at home. There is a strengthening routine for the patient to be done 3 days per week, which includes a warm-up which has thoracic mobility exercise, cat-cow, and side flexion on gym ball each for 10 reps, strengthening exercise which includes the chin tuck with softball, bridging, spinal extension with gym ball, and Y-raise with TheraBand, each performed for 3 sets and 10 reps per set. Finally, there's a cool down which consists of the mobility exercise such as lying on the foam roller, back extension, and the low back stretch. Other than that, the patient should also be performing aerobic exercise for 5 days per week. Patient may perform swimming or jogging at 75% intensity based on the targeted heart rate and perform it for 30 minutes.
Lastly, what are the do and don'ts? So under do's, we always have to stay active. Do low impact exercises like swimming, walking, and cycling. Next is the posture awareness. Maintain good posture when sitting, standing, and walking. Third is stretch daily. Do spinal mobility stretches, focus on the back extension. Last is the breathing exercises. Practice deep breathing and rib expansion daily. What are the don'ts? Avoid bending forward too much. Too much spinal flexion can worsen the posture. Next, don't lift heavy weights. Avoid heavy lifting without help. Stop if it causes pain. Third is avoid sitting too long. Stand and stretch every 30 to 60 minutes. Lastly, avoid high impact sports. No contact sports or sudden jerky movements.
So for all exercises now, you can perform it daily. And remember to stay active. You can do some aerobic exercises like swimming, jogging in your daily life. Also, you must remember to maintain a correct posture with body upright and open your chest and don't lean forward, don't have a forward neck posture. And when you're lifting object, also maintain the correct posture. Also, you remember not to avoid the high contact sports. That's all from our group. Thank you.